Hello, everyone. I'm very excited to be here today with our Director of Nursing, Tiffany Wyatt, and a very special guest that we'll introduce in a second. My name is Narinder Singh. I'm the co-founder and CEO of LookDeep. I spent my first career in technology trying to understand how new technologies could bring innovations to large enterprises. And then I ended up in healthcare as my mom had interstitial lung disease and was unexpectedly admitted to the hospital for a 12-week inpatient journey that culminated in a bilateral lung transplant. And so I was very thankful for the care that she received 7 years ago and 2 grandkids ago to allow her to have that opportunity, and was both amazed by medicine and a bit horrified by how technology supported it. So Look Deep began the journey of helping make sure that we could help bring the attention of nurses and doctors to every patient at every moment through their most sensitive journey. Tiffany, why don't you go ahead and introduce yourself before we get to our guest?
Sure. My name is Tiffany Wyatt. I'm the Director of Nursing at LookDeep Health, and my background includes over 20 years in healthcare, and most of that in the hospital setting. And I moved into the digital health space around 2019, where I built out a team of nurses for remote patient monitoring. And I am very happy now at LookDeep, where I help the virtual nursing, virtual sitting, and our customers really deploy AI and virtual care.
Thanks, Tiffany. And I will allow our esteemed guest to introduce herself in just a second. Holly Lorenz is like a legend in the industry. I was so excited to get to meet her and engage with her as she was transitioning out of being one of the leading CNOs in the country at UPMC. You can see her background, and she has been an incredible advisor to Look Deep on really thinking about how to make care better by making the lives of nurses better. And so one of the things I really appreciate about Holly is this combination of care, direct talk, and strategic thinking that she brings to bear. So Holly, first of all, welcome. And second, would love to hear a little bit about your origin story and maybe a favorite memory or two through your journey as a nursing leader.
Well, thank you for such a warm introduction. I've been really fortunate working in a very innovative health system for the majority of my career, and had the opportunity really early on to start to explore technology before most people were even thinking of that, with putting up virtual sitting actually before 2010, and then doing an EICU, being the first clinician on our e-record journey in the 1990s, and then even having a smart room and deploying alerting that was driven from the electronic chart. So not only that, at the same time, I've had the opportunity to be an executive director over 6 of our schools of nursing. And so seeing what all of this looks like from the eyes of a new graduate, but also from experienced nurses, and it's very different and is intentionally. And I think, to me, the most profound thing for me during all this, regardless of how many years of experience you've had, it without a doubt, the most enlightening things that I experienced when I was a chief nurse exec all felt around communication. Think about this. I was starting this before there was even email. So the communication aspect of my role changed dramatically, over the course of 40 years. But probably the thing that I remember most is my favorite patient. And so as much as my career changed, the focus of it was always really patient-centric. And I think I bookended that as I was doing my doctorate degree while I was almost retired, and I did it during COVID, and it was really looking at the impact of burnout in nurses. I really felt that became a legacy that I wanted to leave, and so I really started to see how we could impact burnout, and my focus was in looking at what the impact was with mindfulness meditation. So I've been very fortunate to really have a career that had all kinds of, journeys and valleys, and I think it's well suited for today's conversation with Look Deep. So thanks for having me here today.
I want to start, Holly, with something actually related to some of your PhD research is the challenges of nursing today, especially with burnout. We've got massive shortages. We have huge number of nurses leaving the profession really early in the career, and overwhelming post-COVID a sense of burnout. And then they're facing huge retirements. They're facing seniors that are growing, and so we're having more and more acute patients. So this is the situation of nursing. And then we see equal challenges inside of hospitals. Tiffany, maybe you want to cover what we're seeing when we talk to hospitals.
Yeah, well, here are the challenges we hear when we do talk to hospitals, and it's often a short staff, the staffing shortages both in nursing, in CNAs, and kind of every area really, and then a lot of the higher acuity of patients. We're hearing that time and time again, and that the nurses are having to take care of sicker patients with the same type of resources. And Holly, how much of this have you been through in your time, last 40 plus years in the profession, and how much do you see of this as new, and how much of this do we just have transparency on the problem that we have always had?
Well, honestly, there's been evolutions of every one of these challenges that I've had exposure to. Staff shortages aren't new. It's just that we're much more comfortable talking about them and really allowing the voices of the nurses to help us manage each of these situations here. The one new thing that has really just started to evolve over the last 18 months, 2 years, and become very prominent, and one that's strategically important to organizations, is that opportunity for how we as leaders or people even in the IT industry can help with nurses feeling safe at work. What we can do from a violence prevention or violence awareness that can really change the work environment for nurses. I'm going to tell you, when you think of staff shortages, nurses have always looked at this as, I need to feel that my workload is manageable every day, whatever I'm doing. So there's different ways to manage that. And technology has been primary for that in the last, more than a decade. And what we as people who are looking at how to solve this or even address this really need to link every strategy that we're doing for what challenge we're really addressing with that. Because I think people and anyone in healthcare sometimes really just needs to be able to connect what's actually happening from a strategic standpoint into what they need from a work-life balance and managing the challenges that you've really done a nice job of highlighting.
Holly, do you think that in your career, let's focus on when you were a nursing leader, do you think the voice of nurses in technology decisions for the hospital is the same, has increased? I think it clearly increased after COVID because of the travel nursing surges, but go to pre-COVID. Do you feel like it was a gradual increase, or do you feel like it was still outside looking in to kind of push for technology change that actually helped nurses?
Well, I think nurses have always been an integral part of that. And when I think of when most people were building electronic health records, it was all about, let's not force the e-record to fall into how we do this in current workflow. But there was a lot of study that went in, and really self-awareness of what the workflow was and how technology could really advance that. So I think that without listening to the nurse, you're going to be so much further in anything that you use to adopt, whether it's with technology or even processes. So I think that's always been a part. I think some people are just more attuned to listening to that.
Got it. Great. Well, let me talk about virtual nursing, because that's a little bit the topic of the day for us. Is that on one hand, it's a cachet right now, right? And I think part of it was after COVID, travel nursing went up, so there was a budgetary reason. And then there was such a shortage of nurses, people were like, we got to invest in nursing. So virtual nursing became the term of the day. And, we've seen things where about half of hospitals say by 2025, they're going to have some level of this in their hospital. At the same time, one thing that's interesting is that we're seeing half of the hospitals that have deployed virtual nursing are saying they're having trouble scaling it right now. And so maybe if you're kind of projecting your crystal ball or looking in through, what do you think is happening that these two factors are occurring at the same time?
Well, I think first of all, everyone initially has had their own idea of what virtual means. And virtual nursing is not a program or initiative to take away the decisions a nurse is making at the bedside. It is really meant to be, one, as a safety check, two, as a way to add a second set of hands, although they are virtual hands, and three, people within the hospitals who are deploying and implementing this really need to start with what's in it for the nurse or for the healthcare provider that's going to want to make them really look into virtual nursing and lean into that as something that can help them. And honestly, probably the two breakthroughs other than virtual sitting have been really looking at what's workload that you can pull away from me at the bedside. That would really make my day easier. And when you think of missions for patients, and you also think of discharging patients and patient education, that's something that people can really get their eyes and hands around and realize if there is a virtual nurse doing that work, I, as that bedside caregiver, have many other things that I can refocus on that need someone there in the room to observe and watch and really do some critical thinking and thinking on their feet with the use of someone in the background. We've also seen it in some instances of being such a wonderful mentor. It's like having a preceptor by your side at all times. And it's not there to say, I caught you. It's there to say, I'm here to help you as that second set of hands, a way of feeling safe in the environment that you thought might have been unmanageable without virtual nursing.
What do you think then is causing, I mean, if you had to guess, like, why do you think people are having trouble scaling it then?
Well, I think that we've tried to adopt it in too much of a mass go live. Get a unit, pick a department, pick an area where you've got the perfect setting of where to deploy this and people can see it's really working. And then allow the nurses that are involved in it, from whether they're the virtual nurse or the hands-on nurse, to describe what they've done to make their workday, their ability to leave work and feel like they've done a good job that day. And if we use those examples and really allow that to be the platform for change, we will be able to get somewhere, I think, more quickly than a deployment.
Reminds me of something the CEO of Salesforce, Mark Benioff, used to say to me, which is like, less changes in a year than you think and more changes in a decade than you can imagine, right? And it feels like that you're describing that kind of piece.
Well, actually, Holly, that's a perfect segue into talking a little bit more, diving deeper into the virtual nursing. And I wanted to talk about this slide and well, I want to understand what stands out to you, particularly important and something that maybe has a potential to scale quickly. And so looking at this, this is how we think about virtual nursing in these categories, but I also know that virtual nursing can have so many more things that they can do, have so much more impact. But, for instance, impact the hospital throughput. You've already mentioned that admits and discharges, but we also see that with ER support or patient family education updates as the patient before the patient gets discharged, so that we can have that discharge process go more smoothly. And then mentorship, you also brought up as being a huge part of virtual nursing, but also dual nurse sign-off, just so you don't have to run down the hall to get that other nurse. And then where we really feel like we stand out is the improving the patient care with AI, which we'll talk about later. So again, what stands out to you is really important, something that has a potential to scale quickly or has the potential to make a ton of impact with some of these things for virtual nursing.
I think there's been adoption probably in the impact of through hospital throughput in varying levels of adoption. And some of that, I think, as we said, it's admission and discharges, and certainly some of the how can we discharge a patient earlier in the day. I think people are exposed to that and understand that very well. I think we have had less opportunity to really identify how we can build a bedside team. Just think if you're a new nurse or even a nurse that's in a environment that something's new happening. In many instances, if there's an event that's going on, there isn't someone that's there for hands on the ground that's right by your side to help you. But if you can call your virtual nurse and say, here's what's happening, tell me if you're seeing the same thing I am, tell me, even walk me through putting in a line that I haven't put in before or something like that. It's like this partnership. And we haven't really sold it as much as a partnership. We've really sold it as you need someone else to help you do this. And so we really need to look at this partnership from someone that's just in time, ready, and available. In my mind, I believe nurses don't really understand all of the things that are in this third bucket of improving patient care with an AI nudge. I think seeing is believing, even if it's a 30-second or a 15-second video of here's what we can do because the patient hasn't been out of bed all day. And we all know that that's the number one reason that discharges are often delayed. Or we can prevent pressure ulcers because there's someone that's going to tap us on the shoulder and say, guess what? This patient hasn't moved or been out of bed all day. So it's allowing someone to call out something that needs our attention that we've been probably too busy. We haven't ignored it, but we've probably been too busy to put that in our workflow for the day. Yet someone's doing it in a way that they've already got the information and they're just helping redirect what we take a look at.
And I completely agree with you on the partnership. And, I hope and believe that in the future, a virtual nurse will just be part of the care team, not so separated as virtual nurse and bedside or hands-on nurse. It's just part of the care team, and that will be something that we'll see in the future.
Holly, is there anything on this list or things you've heard around virtual nursing where you just kind of cringe a little bit and you're like, hey, it's great. The tool is as great as where you apply it, but you can't apply it anywhere. Is there things that you see people doing or even things we've listed here that you're like, I would not start with that, or I'm very skeptical of that being something that's really going to actually have an impact on the bedside?
Well, I am reminded of an early conversation I had with you about the list of things for virtual nursing. And we were focused just on basically this list. And I had 10 other things of where we are with this. And you said, whoa, let's us really nail this so everyone sees this as the initial platform. And then let's start to look at all these other things are meaningful, but really let's not overwhelm, again, what adoption looks like for people. So I believe this is the list that needs our first focus, without a doubt.
You have never been short of ideas, and so I appreciate that balance for sure. I want to talk about the other part of this, which is the money part. So we do some pilots, you do some pilot, industry is doing pilots, right? They get some results, but usually, some of these things take a very long time to measure, like increasing efficiency or satisfaction. How does that turn into retention or care? If you are thinking about look, I believe in the potential of virtual nursing, I need to generate evidence, and I need to generate evidence in a way that gets the CFO and COO on board about systemic change after we've had that success with a unit or a hospital. How would you look at these categories of others to try to build that case to say we need system level change?
Well, let's start with the first one that you've mentioned, the create efficiencies. I think one of the things that I would never do is to suggest to any CFO that if we were to start to do admission and discharges, let's use that as an example because it's really something people understand quite well, as a virtual nurse, then I can reduce 30 minutes of workload from a nurse, and I'm going to save that time. There is a large amount of work on any given day that gets prioritized intentionally. And so what it does allow is the prioritization to actually remove 2 things in the day or 3 or 4, wherever you are. So the efficiencies really are how I can focus on the things that need someone that's there in person to manage. And yeah, it might take away an hour and a half of work that I did the day before, but let me assure you, there isn't any nurse or caregiver that's going to say, you know what, now there's another hour and a half that I don't have to do anything. That's not it. We are able to really focus our attention on where the needs are for that day. And so it's not treating things as equitable or exchange of minutes, but it's really being able to more appropriately individualize the care that needs for patients, because we've been able to remove some work from a nurse or a caregiver's day.
Let me, we'll hit the other categories, but I want to push back a little bit on that because it's the fun part of our discussions. Like, sitting in my mom's room for 1,000 hours over 12 weeks, I definitely appreciated when nurses were available versus they weren't. Because you think, in that context, your patient, your loved one is the center of your universe, right? So that side of me appreciates what you said. At the same time, I think even in past paradigms, how do you deal with the fact that, you have two of your hospitals, they both have 1 to 5, 1 to 6, but one of them has all sorts of support services that support the nurse and the other one doesn't. So they're not doing the same unit of work. And of course, the CFO at some point is like, okay, how are we paying for this? How do we explain that delta? Even aside from virtual nursing, how have you thought about support services and what the right ratio is? Like, I know it's a third rail topic. That's why I'm tossing it over to you to help us think about where efficiency comes from and when it's time to translate it into changes in things that are toxic, like ratio, versus let it make for better prioritization of care.
Well, to be efficient, you need to have the right person, the right type of care person at the right time, who has the right amount of time to devote to give the right care. And the more that we can make that an easier solution, because some things are being removed from the care environment to a virtual setting, the more efficient we're going to be. I'm also going to suggest that any patient that we can tee up having a more complete admission assessment or a more timely admission assessment, or even one that is discharge related, allows us to probably send someone home earlier. Getting someone out of bed is going to send someone home earlier. That allows, patients should be in the hospital when they need the care to be in the hospital. And having someone even delayed at the end of their stay as they're getting ready to go home, when all that patient is waiting for is discharge instructions, and it takes hours because the nurses or whoever is the person designated to discharging people can't get to it, it leaves a very negative, lasting impression as someone's leaving the hospital. So that feeds into this increasing the satisfaction. Even the discharge process can be improved with virtual nursing, and as a result, increased satisfaction. If indeed your virtual nurse is answering call bells, that instantaneous response is priceless to a patient or a family member. And knowing that that's getting escalated to the right caregiver so that they can intervene and take action is really a positive thing. I totally believe that patients and family members don't necessarily care who's responding. They care more that someone responded.
Yeah, I mean, you hit such a couple of very profound points. I think as you were talking, the thing that came to mind for me was that a lot of times it's attractive for the CFO and me or the accountant and me to talk about the numbers like this. And the real analogy is like, we've got a lot of nurses who are underwater, and you're like, hey, do you want to be 2 feet underwater or 10 feet underwater? And the point is, it doesn't matter. You're underwater at that point. And I think what we're seeing is, if we can create the right structure and measurement, the piece is not that we make you, further down or further up and drowning. It's that we're resulting in better outcomes for patients, albeit they're harder to manage. Like, throughput matters to hospital finances, patient satisfaction, HCAHPS scores matter, care metrics matter to everybody because of both cost and the like. And I think it's like, hey, if we can better allocate the time we have a real opportunity to actually create an ROI based on those, versus trying to, decide if we're going to drown under in 3 foot of water or 30 feet of water.
Yeah, I have never heard a nurse say that as a result of virtual nursing, I've had to work harder. And if they did say that, I would question the way in which they deployed their virtual nursing team.
Yeah.
So we need to think about that too, right?
I think one thing you hit that I think is even beyond the scope of the last slide, but really kind of resonated is on the discussion of alarms. I remember, in my one example, my master's at UCSF was in alarm fatigue, which you two are experienced from actually having to deal with it at the bedside. And, it's like something like 95% of alarms are false, but then somebody's got to go be on the phone or walk down to the room, and you can see the opportunity cost of that. And I remember it's very personal because I remember the SpO2 cuff slipping off my mom's finger several times a day, right? But the pattern of that alarm sounds exactly the same as when the pipe from the trach slips out of her neck, right? And one of those is obviously, if you're there and looking at it, you know what's an emergency and what's meaningless. But from outside the room, you're just dealing with another alarm that's false 95% of the time. And so I do think there's some real opportunities for thinking about how we think about care redesign to kind of make us all effective in a way that does satisfy both the CFO, the patient, and the day-to-day experience of the nurse. It's not an impossible mission if we can think about using some things that we'll talk about in a second around AI for that. Let me move us on for a second because you brought up something around kind of the nature of work, and I wanted Tiffany to chime in on how we've looked at that and some questions we have for you on that.
Yeah, so we touched briefly on staff shortages and where that's a really big impact for hospitals right now and has been honestly for a long time since I've been a nurse. And historically we've had shifts for nurses, pretty standards, 8s, 12s, 10s, and to cover most of the hospital 24/7. And we'd see travelers and some outside nurses. And with virtual nursing, we do have the opportunity to give different types of staff, the nurses, a different type of kind of employment option, but we also can have the opportunity to have more hybrid approaches. And so and with that, it looks like possibly, only Monday through Thursday, 8 to 1, that unit needs help with admits and discharges. And then in virtual nursing in general, we're seeing some people going 100% with their own staff. And we're also seeing people having external staff where they're not able to manage the program themselves or hire their own nurses. And we're starting to also see this hybrid approach where maybe you start with some external staff and bring in your staff, etc. So when, Holly, does it make sense to kind of bring this model in-house, and where can you see the need for outside help, outsourcing that resource, and what do you think about the opportunity for these hybrid models?
Well, if I was a chief nursing officer and I was putting in virtual nursing, the first thing I would do is really get a core advisory team of frontline staff together to ask them that question. For people who would be interested, get some influential leaders on units or people who have maybe had experience with this, and allow the staff to make that decision. Think of how much easier adoption is going to be if you allow the nurses to say, hey, or, I experienced in one hospital that I worked with that actually the more senior nurses were who everyone preferred to be their virtual nurse. The nurses that were part of already the unit team or the hospital team, because then there was already this level of confidence and easy ability to not say, well, they're getting to do this and I'm not, but you make that experienced nurses that are interested in this, but make the decision, make sure that you've included the frontline staff and the decision for your model without deploying something that they haven't had any say in.
Mm-hmm. And what do you think about the opportunity for the hybrid models with virtual nursing, with just care when you need it? Do you see that as something in the future, or for virtual nursing specifically?
Well, I think let's use an emergency department as a great example. The flow, it has historical patterns of the busiest times of day. It does make sense to me that there is a version of hybrid nursing in which maybe there's core staff, but then you add to that incrementally and staff that based on where your volume of workload and activity are, because it is going to be different in a surgical unit than it is going to be in an ICU or on a medicine unit. And so it doesn't have to be a cookie cutter model. In fact, it shouldn't be a cookie cutter model, but allow that hybrid option to use the workflow on the unit to determine when the hybrid nurse is in the virtual nursing. Don't let the product or the terminology influence how you build the hybrid model. Use the population of the unit that you're trying to use virtual nursing with. Help inform you and discern what that hybrid model looks like. And to me, it could probably end up being the most successful one.
I think some great insights, Holly. I have on different parts of where care redesign has happened in hospitals. We have, the great debates between open and closed ICUs. We have the rise of the hospitalist as an area. Those are examples of kind of large-scale care transformations. In the nursing side, do you see this, is there an analogy that you think about in your career that, this is like when we shifted from A to B? Or do you think this is a new muscle that's going to require nursing leaders to have these kind of on-the-ground conversations and really kind of build bottoms up because there's no template for this? How do you look at what this change will look like for care design from the nursing perspective?
Well, I'm going to look back a very long time ago, maybe when we moved from 8-hour as a very traditional shift to a 12-hour traditional shift. And now we're really looking at flexible scheduling, which has really just changed the industry in being able to figure out how to do that, because no one's really figured it out, or we would be not having turnover anywhere. So to me, that's an example of things are changing so fast that sometimes we can't implement a solution quick enough to really see the impact in time. And I would use that virtual nursing as the same. We're probably, it's a shame that we hadn't figured this out before COVID instead of building and learning at the same minute, where we could have really built the foundation and then learned much more methodically than really building and learning at the same time.
Fair point. I want to shift gears because I think one of the things that has not existed in a lot of places inside the hospital is dealing with dramatic technology shifts. EHR was the once in a generation shift, but the real thing is that we're seeing a rate of innovation with AI that's very rapid in our personal lives, but trying to keep up with what that looks like inside of a setting where lives matter like a hospital is challenging. And so one of the things we've talked about, and I want to walk through a couple of examples, is how to make AI a partner to the nurse versus feeling like it's somebody who's telling me what to do. So a couple of examples that we think about is we think about kind of nudging action. So for example, being able to say, here's a situation where I see a list of patients, I've just sorted them high, medium, low, who we're worried about for pressure injury. And the AI is watching and saying, well, how do I explain this? Well, we want to make the AI explainable. So it's like, these are the people that are in bed, not moving very much, and haven't been turned for a couple of hours. So now the AI is not a black box. It's like, oh, okay, yeah, I would want to pay attention to those. And for those, maybe I'm going to look in the EHR and see what medications changed, or look at their movement, or even do a video visit with them to ask Miss Smith why she's been a little lethargic this morning. So this is an example for us where the nurse is not being told what to do in AI. It's just that AI can be in every room all the time, whereas the nurse always has context. And I think there's such a strong pairing with virtual nursing because we don't want to overwhelm the bedside nurse with data. We want somebody that can process through this. So by the time we get to a conversation, you're talking to a peer who just seems like they know exactly what's been happening in your patient's room. So this pattern of AI that's partnering with a virtual nurse to help support the bedside team is something that's kind of paramount for us. And I want to just walk through two more examples and get your reaction to the whole group. Another example might be, this is a chart of day by day. Is the patient in bed all the time? Are they starting to walk around the room? Are they sitting in the chair? This patient was in bed a lot. Maybe they had a surgery in bed. Looks like they were up and around. And wait, all of a sudden looks like they had a little bit of a setback. They're in bed a bunch again. And when you look at this data individually, it's somewhat interesting when you can start to put it together and say, here's everybody we're thinking about discharging in the next 48 hours. But all of a sudden you can quickly see these three patients are all blue, meaning they've been in bed literally 100% of the time. It gives you some skepticism that that's true. So these are just examples of where we're not taking decision making away, but we're giving an opportunity for a virtual nurse to evaluate it with the information we're showing, but also the whole context of that patient's care. And so maybe I'll pause for a second before I'll get into more of the real-time pieces. How do you think we go about instituting change in these areas to allow for that bedside nurse to feel like the AI is not my big brother, but it's my guardian angel, especially when paired with virtual nursing?
Really easy example to use is I'm old enough of a nurse that I remember when we saw a lab value. And then miraculously you could see trends. You didn't have to go back and look day after day in a paper chart, that shows you my age, or in an electronic record. It started to trend things for you. So when you trend things, it helps you really be able to use that trend line as someone who's serving up some ability to do some critical thinking for you, or even better, to allow you to focus on something that looks concerning. So it isn't telling you what to do, it's not prioritizing your care, but it's helping you triage through a lot of information, particularly with AI, that we would never have the time to sit and discern. And it doesn't mean we're taking the thinking away, because if you were to see all blue, it doesn't tell you what to do.
Yep.
You need to know what that means. You need to know and decide you're going to intervene on, patient A or patient B with what's happening related to this. And that nudge, I think, is it's like someone who's tapping you on the shoulder.
Yeah. It was once described to me as like, we want to turn AI into the fastest intern you've ever seen, instantly checking on every patient in every room and telling you what's happening when you need to know. And I think that's kind of the pattern that we're looking for.
I was going to say real quick, Narinder, I would take it one step further, Holly, in saying it's not even information to sift through. It's information that nurses have never had before. We have never had this level of information of right. How long have they been in the chair? How long have they been walking around the room? And I think it's really powerful when you start to look into AI to understand how much information it can gather that we want to know that we've never even seen, much less had to sift through like we used to.
And in theory, some of this information doesn't even need to be sifted to a nurse. If indeed the protocol is someone's been blue for 3 days, or maybe it's even a day, that there is a team that's a mobility team that manages that. So it doesn't even have to be a nurse who does the interventions in some of these things.
Yep. Yeah, the opportunities are endless, really.
And I think the thing that we've figured out is this pairing, which we'll talk about later, between the virtual nurse and AI, or vision AI as we call it, is very powerful, because it lets us start with saying, we're not going to impact the bedside at all. We don't have to show you this information. We're just going to be there and say, hey, by the way, your patient was restless all night last night. Okay, great. Now I have some information that I wouldn't have had otherwise. And then maybe over time we say, actually, every time you walk into the patient's room and during a morning shift change, we'll tell you how they slept overnight, and we give that data out. So the virtual nurse gives so much flexibility for allowing innovations like AI to make it to the bedside without having a massive change management exercise when you're still trying to figure out the right pattern. So this is, to me, one big part of that. And a place where we've already seen that is around virtual fall prevention. So, this is a world where you have had the ability to change things in virtual sitting, but we still watch so few patients because it's so hard for a person to watch more than 10 or 12, 15 patients. But with AI, we can set up a safety zone around the patient. The virtual fall prevention observer can adjust that. And then as long as the patient's moving only inside that range, it's fine. But if they start to put themselves in an unsafe situation, we nudge them. And so that's a way that we've kind of dealt with fall prevention, which is a much more immediate feedback, because obviously they could fall. Then you take it one step further and say the AI is going to watch every patient. And now what we're going to do is we're going to leave the final judgment to the human, to the person who's saying, I think they're just stretching versus this patient's trying to get out of bed. Let me talk to them. Let me get them to stay in bed. The AI is surfacing that, but the human decision making is still the humans. And so you get the best of AI being everywhere, but still leaving the person, the virtual observer, empowered. And so this pattern of kind of what we call infinity watch, you can imagine for things that you said, infinity watch for potential violent situations where we nudge and surface that. Infinity watch for pressure injury. Infinity watch for the blinds aren't down in these rooms overnight. You get the ability to kind of think about how we can scale that out very quickly and really make the sense for the patient that the nurse always knows what's happening. They just show up at the right time in my room every time. I don't know how they do that. That's what we're excited about. And I think to something I think, Holly, you're really excited about, which is this is just the tip of the iceberg. These are like just a few of the examples that are kind of moving beyond the initial piece that we could start to think about, from workplace violence to clinical assistance to QI to eventually like real predictive algorithms that say, hey, I'm going to, do your mobility assessment and then you can check it, just like we do with flow sheets today. Having the opportunity of saying, we're going to find, the 1,000 little things that make it hard to take care of your patients, and we're going to provide assistance in that. And so this is a great time for your long list of things. Like, are there things that you think about, like, in this context of, like, I can't wait till AI can do this to help my nurses?
Well, I think it's important, to use the technology term vision AI, and I love that that's what LookDeep uses. To me, it humanizes AI just a little bit because it's about the vision. And so that is a human trait, and it allows us to see how that can be applied to great numbers of patients and very scalable. When I look at clinical prediction, one of the things that we don't think of enough, and you mentioned it with the blinds and things, is the delirium spotter. There are absolutely assessment tools for delirium, but if AI can do that for us, it is so much of a earlier identification, which is key to the resolution and treatment. Septic alerts, when we think of the sepsis alerts that we've seen before, just think of someone's calculating that yourself, not having to do a daily assessment of 6 different clinical items that you're looking at. There is so much that we have not explored. And so I love seeing looking at how you move this to a smart hospital perspective.
So, Holly, it's so great that you're excited about AI, and as am I. And we also know that the whole industry is excited about AI and virtual nursing, but there has been skepticism from many nurses on AI, and particularly because it's perceived as a way to maybe increase ratio or take over their jobs, or as you alluded to it, taking away their decision making. How do you think about that concern, and what would you do, to alleviate that?
Well, it is real. We do know that. And I think it is exposing nurses to what you're trying to achieve. Using, again, a short video or a core team that's going on a site visit that sees what's happening at hospitals that have implemented this, and getting feedback from people who have worked with it before. There's nothing better than someone, in your department, your unit, or hospital that has already had experience with virtual nursing to be a good supporter. I also think that it is really important to build virtual nursing with the voice of the nurse. They're much less skeptical of what it is if they've been able to design the implementation, as well as what are the key clinical things or visual things that you really want AI to do for you. And then sharing success stories. Open every meeting with a success that you've had with a virtual nursing experience, making sure that you're sharing the impact of it, because nurses want to make an impact. And if AI is helping them do that, then they're going to adapt it much easier. And we just need to tell the success stories time and time again.
Yeah, it's such a good point, and I think I'm hearing throughout this whole discussion that bringing the nurses in and really starting with them, and I think that goes with AI as well. And being a nurse myself, I understand where they're coming from, and I also, agree with you that just education on AI and getting a little more familiar with it, and that is exactly involving them. So I think that's huge.
I want to start.
It can't be. I'm sorry. It can't be a stick. It needs to be a carrot.
I think, Holly, you started this webinar with a point that I think is really relevant here, which is like, if we can do things like help nurses be safer in the rooms with AI, which we absolutely can, by giving them the ability to kind of communicate and by just watching for them. Like, hey, we can tell people are yelling in this room, and being able to kind of provide an additional set of eyes on that patient so that they're not, exposed in a dangerous situation. Those are great examples of where it's a real asset to the bedside versus it's just something that you're doing to me to change my job. I think that's a wonderful example of how we can make it more tangible. But I do want to pull to the dark side of this for a second, which is nurses have seen a lot of technology and people say, oh, no, it's great. It's going to make you more productive. And you're like, yeah, it did make me more productive. But then you piled on a bunch more work. You changed the number. If you were a CNO today, and you're like, hey, starting to see value out of virtual nursing, and you're like, no, the answer is not to now add more work. The answer is to use that to create longer term value levers like throughput and patient care metrics. How do you make sure as a nursing leader that it ends up that way versus, hey, this is looked at as just another stick that we start with a carrot and we end up with the stick?
I think you have to be very careful in not selling it in how many minutes nurses say. It's because then when you save it, someone wants to take it away and then give you something else back or take away a caregiver. You have to sell it as a way of, one, being more proactive, because in any time in healthcare, we can be more proactive. Generally speaking, the outcomes are better. The patient becomes more well in a shorter time frame. There isn't as many complications. And so the savings then begin is, I believe, we need to have more peer-reviewed studies on what's the impact of length of stay with virtual nursing, because I don't think we need to have that a little more science related to that. I am certain there's the outcomes, but really starting to do some peer-reviewed literature in this way of which here's how virtual nursing has helped our patients or the operations or the nursing workload without feeling we need to substitute that or change the staffing pattern because we saved 8 hours of time that day. So it can't be an arithmetic approach. It really needs to be a quality of care approach.
Great. I mean, I wish we could almost end there. It's such a great message. And I think, we've done this a little bit on the peer-reviewed for presentations on the AI at a very tactical level. It's one of the things that we really believe in makes a difference for this. But I think you're taking it up a level of saying, like, look, we need to really show evidence for these things so that we can establish best practices. And, minimally for that, not just, so it's not a marketing thing for companies. It's a real kind of transformation of care things for hospitals. I want to zoom out and I'll ask both of you this question. I'll start with Holly because she's our guest. Holly, prediction time. 3 years from now, where do you think we're going to be at with virtual nursing? And some of the AI things that we look, are those step 2 or are those necessary for us to even get beyond the pilot phase with step 1? How do you think about kind of the next 3 years of virtual nursing? And I'll let Tiffany chime in after that as well.
So I think 3 years is still going to be a large part of learning and then some additional adoption, because I think it is going to take a while for us to really get to a point where it's standard of care. That was the same thing that happened with electronic health records. There are now, the majority of the workforce has never worked without an electronic health record. I predict we're going to get to that same point with virtual nursing. The majority of the workforce will never have worked without a virtual nurse.
Mm-hmm. Yeah, and I have to agree with that. I don't think also that will be in the next 3 to 5 years, but right. I do agree also, there's going to be a lot more adoption, people interested in wanting to learn about virtual nursing. I think on the nursing side as well, nurses are going to start to be a lot more interested in virtual nursing. And what is this? Because, it has pretty much, if you've been a nurse, you have a couple tracks and they're mostly in the hospital. So this, I think, will also gain interest in the next couple of years from nurses wanting to learn about virtual nursing and be a virtual nurse. I think that also people are going to realize that the impact, to make a huge impact, you really do need that device in every room to get those AI, or at least on a unit. And I think certain vendors will also understand we need to support the hospitals with their